Bruce, if you could give me a thumbs up that you can hear us all properly in the room. Awesome, thank you so much. Thank you for your patience and welcome everybody today to our introductory to CIRAS. I thank everybody for coming here to the UMB offices in Abuja, and we thank the over 90 participants we have over the Zoom call. I particularly would like to thank the UMB staff here in Abuja for providing this space and helping us set up for this innovative launch that we'll be having this afternoon and morning for you all in North America. So before we begin, just a couple housekeeping. So the order of today will open with some words from CDC Nigeria Country Director, Dr. Mahesh. It will be followed by the presentation introducing CIRAS, which will be presented by Dr. Ted Ellerbrock of CDC's Division for Global HIV and TB HIV Care and Treatment Branch. That'll take about 45 minutes or so. We will then move on to a discussion where we hope that both people in the room as well as over the phone, over the bridge line, over Zoom, will be able to enjoy a discussion on what we hope will be a rather stimulating presentation. For in-person participants, if you would kindly mute your phone or put your phone on vibrate now, that would be very much appreciated. For remote participants, now over 115, we will like to ask you to please write in the chat box your name, title, and affiliation so that we can have a record of the people that we're calling in. I want to let you know that the Zoom will be muted for right now, and we will unmute the Zoom for the discussion. Finally, as a follow-up, please note that the presentation today will be recorded for future dissemination. So if you would like to request the recording and or the slides, we'll make those available. Just please email me at klt9@cdc.gov. That's Kilo Lima Tango 9 at cdc.gov. So with that, I would like to invite Dr. Mahesh to give us a little words of introduction. Thank you.
Thank you very much. I'm not going to speak for very long because I think everyone's eager to get to the presentation. I just want to thank Dr. Ellerbrock for giving this talk, and to also with his team and Dr. With Emilio, sort of talk about what the support and what we're doing here in Nigeria. What we are being asked to do by our funder, to the so-called ART service, to scale up treatment for hundreds of thousands of people living with HIV in Nigeria, is really an enormous task, and certainly in the Nigerian context, it's never really been done before. And certainly it is a technical task. It does require understanding medical, epidemiological, and prevention science. But I think more fundamentally, it is a project of human organizations, how we organize ourselves, how we work together, how do we maximize our time, how do we maximize our efforts, how do we, and I think this is very important, maximize the impact of each of us individually working together. How we can get the most out of all of us. And when I say all of us, I do mean all of us, because it's not just people in the field who are doing their work, but also from those of us who supervise and manage, what are we doing to try and maximize the effort and to really give our teams the direction and the freedom to be able to really do their work. And so some of these things, these principles are being implemented, I would say maybe in a very early stage way, where I like to think that we're like newborn babes at this. And I think, so some of these things will seem familiar to the group here, but I think Dr. Ellerbrock is going to really get into the concept. And I think, I'm hoping that we can learn a lot. And really for us in Nigeria, and I suspect for the other, people calling in from other countries, they'll recognize that we all share the same challenges, and that hopefully the framework and the strategy that we'll be talking about today can help lead us in a direction towards maximizing our impact. So without further ado, I'd like to introduce Dr. Ted Ellerbrock.
Greetings. Good afternoon to all those of you who join us here in Abuja and other parts of Nigeria, as well as other countries in Africa. Good morning to those of you calling in from the United States, the Caribbean, and Central America. And good evening to those attending the International Union meeting in India, and participants calling in from Central and Southeast Asia. Today, we would like to introduce CIRAS, which is an acronym for Comprehensive Integrated Resilient ART System. For those who don't know me, I am Dr. Ted Ellebrock, the Chief of the HIV Care and Treatment Branch in the Division of Global HIV and TB at CDC in Atlanta. Developing this conceptual paradigm and preparing this presentation was a collaborative effort with my colleague, Dr. Durlikoff, who is also a member of the branch. This all began with an ask. At the country operational planning meeting in Johannesburg in March of this year, Dr. Debbie Birx, the U.S. Global AIDS Coordinator, proposed the Nigeria Antiretroviral Treatment, or ART surge. The objective was to place 500,000 people on ART in an 18-month period from March of this year to September 2020. The Nigeria ART surge contributes to larger PEPFAR goals and UN AIDS targets. The ambassador told us that the objective of the PEPFAR goals are to increase the number of people living with HIV on ART by reaching approximately 20 million by 2020. Nigeria is one of 5 states that are surge countries. These are the other 4. However, all PEPFAR countries worldwide received extraordinary FY20 targets. So let's talk about the challenge for Nigeria. As I've explained, the objective is singular and clear. The Nigeria ART surge objective is extraordinary, requiring an extraordinary emergency response. As of March 2019, the Nigeria ART program had enrolled and retained about 750,000 persons on ART since 2004, a total achieved over 15 years. Now we've been asked to enroll and retain an additional 500,000 persons on ART over 18 months. Thus, the objective appears beyond the general capacity of the program based on trends over time. Achieving the objective will require not only intensified work, but also a new strategic approach to program management. The challenge for Nigeria is common across PEPFAR countries. Like Nigeria, all PEPFAR-supported countries need to prioritize activities to reach extraordinary FY20 targets and beyond. To do so, PEPFAR-supported countries need novel strategic programming and a change in traditional approach to program operation and management. However, each PEPFAR country is at a different point in the epidemic, so solutions cannot be uniform. And furthermore, program operations should be locally determined and adapted continually. So the ask leads us to a question. How can we maximize staff and available resources to reach surge objectives? To answer this question, we gained insights from a recently published book called Team of Teams by General Stanley McChrystal and 3 other co-authors. In the book, General McChrystal discusses his experience taking command of the Joint Special Operations Task Force set up in 2004 to confront Al-Qaeda in Iraq, or AQI. Initially, the task force found AQI difficult to engage and successfully combat. Who are these people? How do they communicate? What is their leadership? How do we stop this? AQI defied traditional war operations. They were extremely confused. There was no chain of command. Instead, there appeared to be a dispersed network with a common goal. And all of us know how difficult it is to combat terrorism anyway. But this was a huge effort. Terrorist strikes occurring day after day, hour after hour, and they were supposed to stop them. How to do this? What they decided was they had to change to win. This change was less about availability of staff, funding, and new technology. Rather, they needed to create a new decentralized management approach. In the book, this is what they stated. when we tried to do the same things together and faster. So they started in 2004. So they tried everything they could to increase what they were actually doing. So so when we tried to do the same things together and faster under the constraints of the old system, we managed to increase the number of raids. That's organized interdictions that they could actually organize on a fairly large scale per month from 10 to 18. It took them a whole year to reach that. However, by 2006, under the new system, this figure skyrocketed to 300. With minimal increases in personnel and fasting, we were running 17 times faster. We need to do the same thing for Nigeria, ART Surge, and PEPFAR more generally. In Nigeria, we need to increase the quarterly program growth of new patients on ART from 12,000 to about 74,000, nearly 7 times faster. We need to change the wind. This infographic you see there on the slide was taken from Team of Teams and explains the conceptual framework that they applied for this new system. The caption underneath the infographic is as follows: the speed and interdependence of the modern environment create complexity. Coupling shared consciousness and empowered execution creates an adaptable organization able to react to complex problems. We have adapted insights from Team of Teams to create the core operating principles needed for Nigeria, ART Surge, and PEPFAR more generally. Then we identified essential program components that directly address and support the core operating principles. The core operating principles of the PEPFAR program for managing complexity are adaptability, autonomy and accountability, timeliness and accuracy, transparency and connectivity. Let me talk about each one of them briefly. Adaptability. Currently, adaptability is applied in a linear fashion. For example, the country strategies are developed during the country operational plan process in alignment with OGAT guidance. And this plan is altered in accordance with continuous data collection and program review, i.e. the PORs. However, during an ART surge, the speed needed in decision-making and the increased interdependence between program components creates complexity. For example, in Nigeria, increasing the number of persons on ART by 500,000 over 18 months is unprecedented. As a result, adaptability needs to be prioritized in a fundamentally different way. Let me explain. The surge objectives require a different management approach to address complexity. Let's talk about complicated versus complex relationships. In complicated relationships between program components, it's relatively simple and direct. Ultimately, it yields results through predictable, repeatable processes, as shown in this infographic. Whereas the circles are the program components and the arrows illustrate their relationship. However, we think that what we have now is not complicated, but complex. Whereas the relationship between program components is interdependent, but not always direct. Therefore, the relationship between program components can be unpredictable, as shown in this infographic, whereas the geometric shapes are the program components. The second core operating principles are autonomy and accountability. To acknowledge complexity, the management approach needs to move from command and control to autonomy and accountability. Decentralized autonomy and accountability are essential. As much as possible, activities should be locally determined and continuously adapted. Individuals and teams closest to each program challenge need to be empowered to make decisions. Transparent information sharing across the entire scope of operations provides individuals and teams with the knowledge to make timely decisions in the context of the overall program. Let me give you an illustration of the difference between management by command versus teams. For command, there's an orderly approach to management through clear change of command, such as illustrated here, a typical hierarchy you see everywhere. However, in teams, the members who are empowered to make decisions. The teams are able to interact effectively because it's built on trust and a shared sense of purpose. And teams can continuously adapt to complex interdependent relationships between program components, as illustrated by this informatic. Much different than the one on the left. But it's even more complex than that, because we want to actually manage by command of teams. So within each team, adaptability is possible. However, teams operate in a command silo. Moreover, teams are limited by command-like superstructures, such as illustrated by this infographic. So each one of these nodes is a team, but they're in a traditional hierarchy. However, if you manage by team of teams, which is an organization within which the relationships between constituent teams resembles those between individuals on a single team, you get this. This empowers everyone on the team. This means you're using all the capabilities of the human beings you have, and they aren't restricted as they are in a hierarchy. This is fundamental. The third core operating principles are timeliness and accuracy. Timeliness is crucial. We have a limited amount of time to reach our objectives. However, timely decision-making implementation should be founded on, but not impeded by, a strong understanding and interpretation of data accuracy. Program data always has challenges with accuracy. Understanding program data accuracy is fundamental to data interpretation. In an ART surge, the balance between timeliness and accuracy needs to be monitored and adjusted to maximize impact. General McChrystal stated, when they put this new system in place, we had decentralized on the belief that 70% solution today would be better than 90% solution tomorrow. They were wrong. We found our estimates were backward. We were getting 90% solution today instead of 70% solution tomorrow. The next and fourth core operating principle is transparency. Transparency and information sharing across the entire scope of operations is essential for this approach. Shared understanding of the entire scope of operations enables effective and decentralized decision-making. Then, individuals and teams can self-filter the increased amount of information to what is relevant to their local program operations. The risk of information being spread by mistake is surmounted by the benefits of being able to act in a timely fashion. The fifth and final core operating principle is connectivity. Connectivity needs to be created across the entire scope of operations. Connectivity requires building trust and a shared sense of purpose. Impediments need to be identified and overcome to establish connectivity. To strengthen program operations, lateral connections need to be created between siloed units. These are the core operating principles of PEPFAR programs for managing complexity. Let me briefly review them with you again. Adaptability, the resiliency needed to manage the increased number of and interactions between independent program components. Autonomy and accountability, decentralized empowerment of decision-making. Timeliness and accuracy, increased speed in decision-making based on interpretation of best available data. Transparency, increased information sharing across the entire scope of program operations. And finally, connectivity, create connections across silos to build trust and shared sense of purpose. Thus far, we've learned, adapted from team of teams, the 5 core operating principles that are necessary for managing the complexity of our PEPFAR program. Moving forward, We need to ensure that our PEPFAR programs are prioritizing the program components that support these 5 operating principles. So let me introduce CIRAS, the Comprehensive Integrated Resilient ART System. The new PEPFAR targets and timelines of the ART surge in Nigeria and elsewhere require a fundamental change in the traditional approach to program operations and management. CIRAS is a conceptual framework to prioritize ART components around managing complexity. The core operating principles bind the program components together, creating synergy that increases impact. CIRAS provides a framework for managing operational complexity, a systematic way to identify essential program components through an understanding of the core operating principles, a tool to create a shared sense of purpose around a clear program objective, and promote transparency in the priority setting process. This brings us to another question. When we talk about CIRAS in action, how can we use the core operating principles that I've just explained to you to identify the essential program components, which are the concrete activities that we do in this new system to ensure our PEPFAR programs are set up to manage complexity? This shows you CIRAS in action for the Nigeria ART surge. Remember, those are the core operating principles in the middle in blue. And the essential program components are in green on the outside. And they are the Nigeria AIDS Indicator and Impact Survey, or NICE, the Incident Command System, ICS, Granular Site Management, GSM, Indigenous Clinical Mentors, Electronic Medical Records, or EMR, National Data Repository, or NDR, ART Surge Dashboard, Project ECHO, South-to-South Learning, and Continuous Quality Improvement, CQI. Let's review each one of those briefly. NICE, the Nigeria AIDS Indicator Survey. As all of those of you in this room know, that we just completed the NICE recently. It was an unprecedented effort that was enormously successful, costing $100 million and requiring 500 vehicles on the road the same day. Before we started the NICE, one of the reasons we had to do NICE is we just couldn't figure out where the HIV positives were. And in fact, for years, we thought that the prevalence was 3.2 or 3.5. That's what all the best estimates. But in fact, what we found was the national evidence was half that, 1.5%. An enormous finding. But for the surge, what was really important is we got the prevalence per state. As all of you know, there's 36 states and FCT in Nigeria. So where are the people? As you can see by this map, which is color-coded, in the darker colors were the higher prevalence, most of the people who needed to go on ART were in the southeast or the south-south. And so this provided the basis for the surge, because now we knew where the positives were and where we need to put our programs to be effective. So we selected 10 states. First of all, Akwa Ibom and Rivers, they were called the priority states, okay? In addition, we selected additional red surge states, which also had high unmet burden: Lagos, Enugu, Imo, and Delta. And then finally, 4 additional selected states: Gombe, Abuja, Nasarawa, and Benue. So this told us where we had to surge. And so that's one of the reasons why this is an extremely important program, essential program component. The next one was Incident Command System. We decided that with this new approach, we had to put in place something that was designed, organizational, and been tested over years, successful in a big effort like this. The Incident Command System, ICS, was originally developed in the 1960s to effectively, efficiently agencies across multiple jurisdictions fight forest fires. The forest fires in the United States cover many, many square miles and require thousands and thousands of people to fight and many different agencies who have to be coordinated. And this has worked very successful fighting these huge forest fires where thousands of people are actually in the forest fighting the fires, man to fire or woman to fire. ICS is an adaptive model for responding to large-scale events in addition to forest fires, including public health challenges. ICS has been used to manage WHO-designed public health emergencies of international concern, for example, Ebola from 2014 to 16 in West Africa, and now currently in DRC, as well as Zika in 2015 to 17 in the Americas. This is an organogram which shows you the structure of the ICS. At the top, where it says IC in purple, that's an incident commander. There are 5 major organizational divisions within an ICS. One of the reasons they had safety here is because it's very, very dangerous to fight forest fires and to work in many of these emergencies. And so we actually need that here because of various safety concerns for the workers in different states. So there's actually 4 other subdivisions, OPS, which stands for Operations, Planning, Logistics, and Finance. Let's talk about operations, how we're applying it to the Nigerian surge. So if we look at operations and we look at the 9 states that CDC is responsible for, but I must admit that DOD and USAID are also working in Lagos. And the one state that's missing is Akwa Ibom, which is overseen by USAID. But let's just talk about these as an example, okay? You can see these are the 9 states, and the CDC team here has a CDC Nigeria operations chief at each one. These are all the ISMEs and the staff from the HIV care and treatment branch, a total of 15 people who have been embedded in the program in selected states. Their responsibilities in those states are actually being placed in their work plans. So they're responsible for hitting targets in each one of these states as an integral part of the teams. However, as we said before, we don't want a command of teams. What we want is a team of teams working together. So this looks like the same old hierarchy, but we don't plan to keep this. We plan to create this. Each one of these geometric shapes has the initials of the CDC staff here and the embedded staff. This is how we hope that they interact, okay? And so what this does is that the hierarchy places limits on what you can do. It tells you this is what you're responsible for. So even though you have more capacity, you can't do that because that's not your job. In this system, everyone is capacitated, but you can't make decisions unless you have the knowledge. So that's the reason we need transparency and connectivity. So all the information is readily shared. And so the video conferencing system we put in place will be accessible by everyone at all times. The dashboards that we will create, which goes down to the site level, will be available in real time for everyone to look at their data, okay? Everybody has access to all the information. The third component, granular site management. We have thousands of sites we're applying ART. We can't possibly go to all those sites, but we can correct the main problems of those sites. So we focus on a limited number of sites. We use site-level data to identify specific problems and solutions and apply CQI. We go beyond just telling the partners what to do and the partners telling the site people what to do. We go right down in the site management, everyone. Because we're at a limited number of sites, so we can do that. So we can drill down and do the deep dive. So we create site-specific teams with staff from the PEPFAR agency, in this case CDC, the Ministry of Health, implementing partner in the site. And then we make sure that the leadership is invested in this, okay? It's very simple. They've tried it in Malawi, in Zambia, and I can tell you this, both countries are close to 90-90-90 now, okay? Because they did surges starting 2 years ago and a year ago. They've applied granular site management, clinical mentors, and ECHO, and me, they're almost there. And we've brought them here to work with us, and I'll get to that. So this is an action plan for granular site management at a specific site. This is a real one, Okay, it's very, very simple, used in Zambia. It has only 3 problems. We want to keep it really simple. So we identify a problem, root causes, the recommendation to do, the person responsible, in a time frame. It's very simple. Many of you folks are field operatives to understand how this works. But let me show you a very interesting cartoon which explains exactly how this works. There's lots of sites with many challenges. We know that. We focus on high volume and high priority sites and do a deep dive with these teams to understand the challenge and develop solutions. Now remember, the partner is there. So it's interesting, once the partner learns a big solution to a major problem that's common in all their sites, spreading that information is almost instantaneous. So we take the lessons learned and best practices, and it spreads almost instantaneously in Zambia and Malawi to the other sites. So we actually scale up by figuring out the problems at selected sites, and then information gets dispersed to all the other sites. So we can make a difference in 1,000 sites by only working at 100. Component 4, indigenous clinical mentors. This idea originally started in Namibia years ago, and it was the Ministry of Health that did it. Simon Aguilari, who was in Namibia, took it to Zambia and applied it there. It's incredibly successful. They had 30 mentors until recently, just had another training. I think they're up to 50 or 60. There's a clinical mentor in every district. As PEPFAR programs grow rapidly, PEPFAR agency staff need to improve ART coverage while also ensuring quality of HIV services. To implement granular site management nationwide, agencies' reach can be extended by hiring indigenous clinical mentors to act as agency surrogates at the local level. Indigenous clinical mentors are selected to provide agency oversight at granular site management sites in selected geographic areas where ideally they live, allowing for frequent site visits. They're trained in PEPFAR program priorities and closely monitored by a chief clinical mentor. We set this up in River State. We have a clinical mentor. They have a video conferencing discussion every week. You can dial in. And in frequent contact with agency country staff through video conferencing. They use CQI to develop and implement solutions to site-level problems, monitor progress, and rapidly spread effective ideas. This photograph shows 4 indigenous clinical mentors training to support ART surge in River State this month. The 5th component, this is something you're all familiar with, electronic medical records. Site-level EMR provide important opportunities to improve site-level data accuracy, analyze site-level data for program improvement and improve patient outcomes, centralize patient data within a site. The availability of site-level data empowers local ownership of solutions and enables timely decision-making. The 6th component, National Data Repository, or NDR. The NDR serves as an integrated data repository for the collection of patient-level data on diseases of public health importance, including HIV. These are very, very important. The NDR creates a uniform standardized data set from all sites nationwide, allowing for aggregation and analysis. Provides patient and program data from all sites in near real time. Includes data quality control algorithms to improve data accuracy. And features an online portal for data visualization and dashboards such as this. So this is an NDR online portal. And as you can see at the top in the black box, these are active patients with within the last 28 days. In the blue box, it's active patients lost to follow-up within 90 days. And below that, you have the patients currently receiving ART by sex and the patients currently receiving ART by age group. So this is something that the NDR is really absolutely essential for a surge such as we're trying. The 7th component out of 10, we only have a few more, is the ART Search Dashboard. The dashboard is an Excel-based tool that enables transparent data sharing. It's updated weekly for all the surge states. The dashboard includes data and visualizations for the aggregate, state, and site level for key program indicators such as HIV testing, persons newly initiated on ART, persons on ART, linkage, and retention. This shows our current dashboard. And you can slice this in a variety of different ways. This is an aggregate for all the 10 states that are currently involved in the surge. But you can just by clicking on the state's name, it will change and give the results for the state, or clicking on the partner, or clicking on multiple states together, it'll all change automatically, all these data outputs. And in fact, you can actually click on any one of these outputs and lift it up and put it in a PowerPoint slide. In addition, now, just recently, this goes down to the site level. So in near real time, we have current data on all the sites in Tier 1 and Tier 2, which includes about 80% of all those on ART, 80% of all those on ART in the 10 surge states. The eighth component is Project Echo. Project Echo is a learning platform that uses video conference technology to decentralize knowledge and spread best practices about the diagnosis, care, and treatment of selected diseases, including HIV. It's actually spreading around the world. We started the first Project Echo in Namibia in 1985, and it spread to, the last I heard, was about 18 countries, and they just started a huge TV Echo in India with a $10 million grant. The Echo model enhances learning and monitoring activities through case-based learning, sharing of best practices, evaluating and monitoring outcomes to understand impact, and using technology to leverage scarce resources. The ninth component, South-to-South learning. This is a picture taken in Lusaka, Zambia, of a group from Nigeria to meet with CDC staff in Zambia to learn about the Lusaka surge, and we met there in November of 2018. This is another photograph that was recently taken showing CDC Zambia, including one of their partners, the Circle of Hope, which is an incredibly effective organization in enrolling key populations and men. They visit us to help us implement a community testing strategy in Delta State last month. And finally, continuous quality improvement. CQI, this is the 10th and last component. CQI applies scientific methods to implement, analyze, and improve program performance. For ART surgeons, CQI is needed at all levels of program operations and management. These essential program components are comprehensive and integrated, working in synergy to enable program resilience. The position of essential program components is associated with their strategic relationship to core operating principles. The Nigeria essential program components were identified using core operating principles. So let's visualize the essential program component interdependence. In a complex world, essential program components are interdependent, although not always direct. Mutable, differing over space and across time. Let's take a few examples. The results of the NICE were used to plan the incident command system. Site-level electronic medical records, or EMR, send patient-level data to the National Data Repository, which is used to create the dashboard. Indigenous clinical mentors should use Project Echo for South-to-South learning and granular site management, which should include a review of data from the dashboard, using continuous quality improvement to further the surge objective under the incident command system. So in summary, we actually like to answer one more question. How can you use CIRAS for your PEPFAR program? 6 steps. Step 1, collectively create a well-defined common program objective. In Nigeria, we know what it is. It's $500,000 on ART in 18 months. Number 2, review core operating principles to manage complexity. The core operating principles should be ordered for each country in the way that makes the most sense for the objective and ART program. We also recommend that everyone read Team of Teams and a recent publication called One Mission, whereby the conceptual framework described in Team of Team is applied to larger organizations such as Under Armour in the United States to deal with problems that they have similar to what was going on in Iraq. Step 3, collectively discuss which program components are key. Then discuss which program components directly address operating principles, as we're doing here for Nigeria. The 5th step is discuss which program components support operating principles. Finally, discuss how additional program components may contribute later. And finally, reassess program objectives and program components around operating principles. Thank you very much for your time and attention. We would like to acknowledge the following individuals from the HIV Care and Treatment Branch in Atlanta, plus CDC Nigeria, CDC Zambia, and CDC Malawi.